Thanks very much for asking me to speak here. I'm actually very familiar with the rain in Vancouver here. I was here for 3 years a few years ago, at which time I returned home to Manitoba to carry on my quote-unquote research. So I'm going to start with some disclaimers here, not the usual, I took money from pharma, or I took grants and so on, but disclaimer, the types of research that I do. The types of research I do is nothing to do necessarily specifically with things like graphs and charts that most of these talks typically have. Nothing to do with test tubes and beakers and pipetting solutions and so on. And certainly nothing to do with killing rats or mice or rodents in a lab. I do research of a different nature in terms of health services research, in terms of optimizing care for patients, really taking things from the policy level to the bedside, so a different type of translational research. These types of talks typically focus around a story or an anecdote, and this is something very impactful to my life, is in January 2012, things were going pretty good for me in Winnipeg. I'd settled into my career, had a nice home, great colleagues to work with, and it was, some of you are very familiar with Winnipeg, and moving from Vancouver to Winnipeg, the weather's a bit different there in the winter. Last year, again, we had, I think, 40 or 50 days where it didn't go above minus 30 for a while. But the year in 2012 was really, really great. We had a winter which kind of was 0 and minus 5 pretty much all year. So this prompted us to actually go outside and do some socializing. So I booked a restaurant, High's Steak Loft, one of my favorite restaurants, to go for a meal. And my wife, who was about 3 months pregnant at the time, and I reenacted a selfie of us about 5 years earlier when one of our dates we went on. We were a little bit younger. Getting ready to go, had a beautiful dinner, had a lovely glass of Cabernet and a beer, and we're walking outside afterwards. 12 hours later, this is my x-ray on your left side, and you can see 2 distinct fractures in the jaw after I was, hands in my pockets, walking, slipped and fell, and was spitting out teeth and blood on the sidewalk. And this is me post-op day 1 with an ice pack circumferentially around my face and my jaw wired shut. So what had happened was, I'm 6'7". I had my hands in my pockets, and I was walking, talking to my wife, and there was a few factors here that you would be able to see why this could happen. What was my risk? This ordeal cost me, I'm 6'7", and I'm about 200 pounds today, cost me about 30 pounds of weight loss in a month. Cost me about 13 fractured teeth, 2 implants, a bone graft, agonizing 6 weeks of my jaw wired shut, and I love to talk, and I wasn't able to do that very well, and about $20,000 in, some of it insured, mostly not, bills for dental work and so on. Could you have predicted this would happen? I'm 200 centimeters tall. It was minus 5 and a very warm winter in Winnipeg, therefore I was wearing, which you guys wear every day, it's very fashionable, slippery Teflon running shoes. And because I'm tall, I tend to hunch over when I talk. I have my hands in my pockets. My risk score for falling and slipping on the ice was very, very high. So this article was in the Free Press about a year later after I'd sort of subsided, and I was asked when I was waiting for my drink at Starbucks by a young woman why I was wearing a nice suit and big winter boots. So this is my public health message, and when I told her the story and it ensued, I got a call from the Winnipeg Free Press about 2 hours later. I was getting a photograph, and then I actually was away the next day. My mom called me that I was on the front page of the paper with my public health message to all. So Manitoba isn't always winter and snow. We probably like that about a month or 2 of the year. We do have a very beautiful province. We are the center of Canada, opposed to what my Toronto colleagues might say. We have a very unique demography there. We have a population of about 1.3 million people, of which 800,000 are surrounded in the sort of the Winnipeg area, which is about an hour from the US border. 15% of the province of Manitoba is First Nations. The demographics look very different than anywhere else in Canada. We have in Manitoba, again, our nephrology group takes care of most of the dialysis patients in Manitoba. We have 1,450 dialysis patients, so we lead the nation, not a badge of honor, in incidence and prevalence of kidney failure. The First Nations patients in Manitoba occupy triple or quadruple the dialysis spots in Manitoba. So 40 to 50% of our patients on PD and hemo, et cetera, are now First Nations people. So this is a public health emergency with a very vulnerable population in Canada, but specifically in Manitoba. So this graph, again, I looked at some of the administrative data over Manitoba, some of the claims data for dialysis growth, saying why are we growing so fast? Why do I read in the Globe and Mail Medical Journal that parts of Ontario and parts of Vancouver and BC, dialysis rates are leveling off, if not even dropping, and why are we growing so much? So we wanted to look at different sectors. So most of these graphs you look at, it's usually, yeah, you know what, we have an aging population, it's 65 to 74, you'll see some linear growth, 75 plus, you'll see some logarithmic growth. But this graph is very interesting to me in that it's very location-based in Manitoba. If you look at the south, if you look at Winnipeg, Brandon, other major urban centers in the south of Manitoba, we do have that aging population. There is some growth there. The majority of our growth, in fact, logarithmic growth over the last 25 years has been specifically in northern Manitoba, rural and remote locations. Shifting gears a bit, we know in the healthcare system, we're likely not getting best value for money. This is one example of a study that's been done, but there's been many studies done across the world about is the Canadian healthcare system getting good value for money? I'm not going to say we're a bad healthcare system. We do rank in the lower, depending on how they rank these things. In terms of efficiency or access, we usually rank in the lower sort of tertile of the economically advantaged countries, the Western countries. But certainly we do spend a lot more on healthcare than maybe we're getting back in return. And I've done a lot of these administrative courses and so on where hospital administrators get together and they say, you know what, let's just actually do more home dialysis and then we'll save lots of money. It's a real quick win, and we all know there's a lot of challenges to that. But just to highlight the cost of dialysis modalities, we know that home peritoneal dialysis or home hemodialysis are likely substantially cheaper than facility-based hemodialysis, and this is even more the case in Manitoba. I alluded to that graph earlier. We've done a study in Manitoba looking at our costs of our satellite dialysis facilities. So most of our satellite facilities are probably costing similar to what they would in Winnipeg, $80,000, $100,000 a year, depending on where it is. But we do have some of these communities, you'll see these top graphs, $200,000 or $250,000 per patient per year to dialyze in these rural, remote communities. The top one there is Garden Hill, Manitoba. Garden Hill, Manitoba, I'll allude to later on, is on an island in the sort of northern part of the province. It's a beautiful place. There are 3 communities that surround Garden Hill for that island. So during the summer, patients are boated back and forth to dialysis, but as you know, there's a lot of freezing in northern Manitoba. And during the freezing section, or if it's windy, or if there's sort of the ice is not totally frozen over, patients are helicoptered back and forth from dialysis. The helicopters cost about $800 per hour. These are sort of third-party vendors that deal with helicopter rentals. $800 an hour to, $800 from 3 different islands, so the different helicopters go to each island, or different communities. And this happens 6 to 8 months of the year. Because there's no hospital, there's no stat lab ability in these communities, anytime anybody gets very minor medical problems, they're medevac back to Winnipeg for about $10,000 life flights. You can see these costs get astronomical over a period of time. And we know that even if without shifting patients to home dialysis or doing other things, this is really not optimal value for money. So some principles I want you to take home today that really, I think across the board, we know there's no new money in healthcare. We've been asked in the Winnipeg Regional Health Authority to trim our budgets by 4% over the next year, and this has been sort of an annual thing. Trim these budgets in an era where nurses are getting raises appropriately, where physicians are getting raises probably inappropriately in some cases. But their levers that we can control in terms of, besides trimming supply budgets and so on, are very, very small to actually trim these healthcare budgets. We need to serve the entire population. So if we are a renal program, it's not enough to say, we're going to serve these patients like we've always served them, and if there's new patients coming in, no, you have to wait, or you're not going to get good care until we get more resources. That's not an option in a public healthcare system. So therefore, it requires the third principle is we need to align our resources to best take care of the entire population. And we need to align those resources with the patients who need it the most. It's a simple principle we use in all of our emergency rooms. The patients that are the sickest get seen first, they get the resources applied. We have to apply this to chronic disease paradigms as well. So how do you do this on a renal program level? We know Manitoba's got a public health emergency with regards to First Nations patients. We need to systematically find the problem and how to best align resources with risk. So this is a simple construct. We did a model in Manitoba of a simple construct of where do our patients come from, how do they enter the renal program, where do they go after that, and where do they end up? We want them all to end up with kidney transplants, of course. And we really want our patients who are at risk to be referred early from outpatient clinics, get into our kidney health clinics, maybe into our multidisciplinary clinic, transition onto peritoneal dialysis or home hemodialysis, eventually getting a transplant as soon as possible, and staying off the really resource-intense modalities like hemodialysis or satellite hemodialysis as long as possible. So when we set up these simulation constructs, the point is not, there's a lot of data here, but where are our transitions occurring? Where is the key places that we could influence the path patients take, and where should we work on getting our processes the most efficient? If we melt away all those things that have minor transitions, it really boils down to that kidney health clinic. The clinic where the transition stage where patients go from outpatient clinics and are transitioned onto dialysis modalities. So if we do nothing else to get our own house in order to take care of all the patients in the population, we need to get those processes very much streamlined. So shifting gears, this is me in 2007, September. And I just arrived to Winnipeg from Vancouver, and I'd armed with my Master's in Health Administration and a nephrology fellowship with Dr. Levin, and I was with Jag and Monica, and I was a fellow, so I knew everything pretty much. So I showed up on my second day, and I had my spiky hairdo and my clinical coat and a couple of unit clerks there. All right, my clinic's here. I have 30 patients to see in 4 hours. Okay, that's a lot of patients, but I can probably organize a system fairly well. And I went into my first room, and 4 doors slammed in front of me. There was a research coordinator enrolling a patient into one of our clinical trials they were running at the site. There was a pharmacist who ran into another room, whipping in and out, trying to get prescriptions faxed from the local pharmacy. There were nurses, 2 nurses in 2 of the other rooms. There was a dietitian with a box of food models and steaks and things like that roaming around. And I couldn't get into a room. And this was a big problem. And eventually, I didn't know what anybody was doing. Some patients were getting seen by certain practitioners. Some patients were getting seen by others. By the end of the clinic, it ended up just being me there, and everyone was gone for lunch. And I saw all my patients, and I just did the best I could. But I was spinning around, and I became a very, very unhappy, sick kidney doctor from a process perspective. And I went to our medical director and I said, Dr. Vereldi, the medical director at the time, this is not working. This is a very inefficient clinic. He said, Paul, this isn't Vancouver. You know, like things work differently here in Manitoba. It's like they do things their way, we do things our way. Our way works really well as well. And I said, it's not efficient, but I'll give it a few months. And I gave it a few months, and it was not getting any better. And I was getting more and more frustrated. So I bought some pizzas, sat some of the allied health nurses around, and we talked, nurse, what do you do in the clinic? Well, I look after the symptoms. I teach about dialysis. I review the blood work, review the medications, and I give a sort of head-to-toe exam of the patient. Pharmacist, what do you do? I go over the blood work. I go over the anemia. I ask the patients about symptoms, so do a general medical history. Dietitian, what do you do? I go over the blood work, medications, review sort of a head-to-toe of the patient, talk to them about dialysis. Everybody was doing the same thing. Nobody was really working as a team. So we know that teams or interdisciplinary teams are a good idea, and this is a very common problem because I give this formation of this talk, a lot of different places, and there's a lot of heads nodding. Teams are a great idea, but we don't know just by throwing resources in a clinic and some rooms if they're performing well, if they're more than the sum of their parts. And we really have no metric, a standardized metric, to measure team performance. So I've done extensive process analysis studies, and I wish I had the technology that sort of some of the technology Daniel's describing, but the technology that I had at the time in 2007 was 2 engineering students and some stopwatches. And they went in, and without saying anything we told people they were going to be there, process engineers. The engineers showed up on the first day, they followed a patient through, and they said, this is an engineering student, he's going to be following you through the clinic. New patient said, why do we have an engineering student in the clinic? By 3 hours later, when they were at the last practitioner, they said, I know now why you have an engineering student in the clinic. Because they were asked the same question time and time again, and it was literally taking 3 hours to get through maybe 45 minutes of practitioner time. But this is just one example of one of the time studies we did across 12 physicians at Health Sciences Center, a center I'm not a physician at, but ours is just as bad, is that new consults on the left there, we're seeing on average, this is like in 6 weeks of data, by one practitioner by about 12 minutes. As low as 8 minutes for a new consult, physician 10 there. And physician 7 there was paying on average about 40 minutes, as high as an hour for a new consult. So these are clinics that have all these resources, a limited number of rooms, lots of patients to be seen, and yet there's that much heterogeneity in practice. And I can tell you it's the same for dietitians, for nurses, for pharmacists, for social workers, lots of heterogeneity. We actually did further studies on what they were doing in the room, lots of heterogeneity. And really, there was really no standard operating procedure by which practitioners ran. Similarly, big frustration was the rooms are always shut and I'm waiting to see a patient. 40% of the time, or 36% of the time, there was idle rooms or patients in a room with a practitioner who was idle, but that practitioner had already seen the patient, so they couldn't even go into that room. So just really no sequence of events. and no standard way the clinic was running. So what we decided to do after a long series of about a year of meetings was at least establish a sequence of visitation. So patients would see a nurse, a dietitian, a pharmacist, and a physician in that order, always in that order, and every practitioner would see every patient for those deemed needing interprofessional care. After 3 or 4 years of running this, we now in the renal program have a standardized template that all patients deemed needing interdisciplinary care can expect to spend 15 minutes with a nurse, a dietitian, a pharmacist, and a physician, and all practitioners have standard operating procedures by how those clinics operate. So we have a predictable amount of time patients are seen and a predictable number of resources we need in the clinic and rooms and so on. So that's at least getting your clinic in order. There can be some debate among practitioners if this is necessary, but at least we do have a standardized template of how patients needing interdisciplinary care go through the clinic. So we have our own house in order somewhat now in terms of the most, I would suggest, the most important part of the renal program. But what are our overarching goals of a renal program? I would suggest they're to deliver prompt and efficient care to patients at high risk of progression of CKD. It doesn't mean that you're seeing everybody with CKD, but at least people who are at risk of progressing to needing dialysis. We need to provide appropriate triage and resource-effective care to patients at low risk of CKD progression. So we need to really treat low-risk patients cautiously. We don't need to over-treat them. We don't need to over-resource them. And we overall all want to reduce the burden of kidney failure in Manitoba, which is a real public health emergency, as I showed you earlier. So how do you align resources with risk better? Well, this is one example, and many of you are familiar with this, these KDIGO staging guidelines. We know that when we launched estimated GFR reporting in BC now for almost 15 years ago, referring everybody with a GFR less than 60 to nephrology is not an appropriate way of functioning. There's too many patients out there at low risk who really don't need to be seen by nephrology. And really we needed a better way of predicting who is at risk of progression. So this is the first step at that. We can kind of see that the people are in red there who have lots of proteinuria, who have lower GFR, likely need to be seen by nephrology or interdisciplinary teams sooner. The people in the sort of orange and yellow bars there who have sort of moderate GFRs, a little bit of proteinuria, need to be treated cautiously. And the people that are green are very low risk, probably are best managed in the primary care setting. This hasn't overtly been stated, but it kind of makes intuitive sense. And this is great for nephrologists. We all know this, high proteinuria, low GFR. We know those people are at high risk. So let's throw it out there into the community. When I give this talk and I show this graph to primary care physicians, they kind of laugh. This is great, but we have one of these for every single cancer diagnosis, every single sort of polyp screening for GI cancers, for head and neck cancers, for prostate screening. They're inundated with these types of tools. It's just not that easy to integrate into clinical care when maybe you'll see one CKD patient over a period of 2 or 3 days in a clinic, and to sort of find your way on proteinuria and GFR. It can be done, but most family physicians just don't have time to do this. So it's really not that easily implemented into clinical care. One of the nephrologists that I work very closely, Dr. Tangri, as well as others in BC, have come up with this Predictive Model App for detecting sort of risk of kidney failure, which is, again, highly validated and highly accurate for predicting 2 and 5-year risk of kidney failure. It's easily integrated into the handheld app. QXMD Calculate's one of them, but it's available on every platform. And it's good, again, if you have the time to enter things into an app. What's really great about it as well is it's easily integrated into electronic medical records, electronic kidney health records, and so on. So we can now push to individual primary care practitioners risk of kidney failure and whether or not patients really need to be seen or referred to nephrology clinics. So in 2011 in Manitoba, we had launched EGFR reporting a little late, probably in 2009, 2010, and we had site-based referrals. So we have 3 main sites in Winnipeg we get referrals from. And after EGFR reporting about 18 months later, our wait list for new nephrology referrals had swelled to approximately 230 days. At one site, it was actually 1.5 years to see a non-urgent referral. So semi-urgent referrals, the physicians were triaging things, but we're just saying, yes, we'll see it, and we just get to this big pile, ever-growing stack of referrals to be booked and seen. We need to do something different. So we started doing risk-based triage of all new referrals. We hired a physician assistant, and any new referral coming in, we sort of demanded, unless they're really, really high-risk features, we demanded, and we searched on databases and sort of our eChart Manitoba, which is all the sort of labs in one place, for EGFR, some form of urinary ACR albumin, all the sort of biochemical factors we could find that would actually be able to enter into this app. And we said, we'll set a fairly low threshold to see all new referrals. Anybody with a kidney failure risk of about 3% in 5 years or above, we'll see. And anybody with any other high-risk features, hematuria, pregnancy, polycystic kidney disease, we'll book as well. And if we get a second request from a physician to see a patient, we'll see that referral right away, immediately. What we found was about 40% of our referrals went back to primary care. They were low risk, they were very ultra low risk, and family physicians just wanted to say, you know what, that's great, I know I'm doing the right thing, I don't need to refer everybody. We would get the occasional referral back, which we'd book immediately, but most of the time, people were quite satisfied that their low-risk patients weren't being seen. And we were able to book all these sort of 3% up risks almost immediately. And our wait list was dramatically cut. So after 2 years of risk-based triage now, we now have a less than 1 month wait for any new referral at our 2 sites, St. Boniface and Seven Oaks Hospital in nephrology. So we went from an 18-month wait list down to really down less than a month. And a lot of that was not new capacity, but just because a lot of those referrals we were getting were relatively low risk. So we have our own house in order now for interdisciplinary care. And those patients that are really at high risk, over 15%, 5-year kidney failure risk, get into our interdisciplinary care clinics. We have our own house in order. We were able to take on new referrals relatively quickly or triage them sort of out there virtually before they're actually seen by nephrology. But we still have this huge issue with First Nations patients from northern Manitoba, where nephrologists or even primary care, basic primary care infrastructure does not exist. So again, you have Garden Hill, Manitoba. They have a dialysis unit, $250,000 a year. They run it with a few nurses. There's no physician there on site. But they have no primary care infrastructure. They have a nursing station that's inundated with tons of problems day to day with 5,000 people living there who are very sick in very poor conditions. They don't have time to do proper chronic disease workups and screening. We started the FINISH project about 2.5 years ago, which again is trying to institute point-of-care testing and instant risk prediction in the field. So we don't need to bring everybody down to Winnipeg. Not everybody has a family doctor. There's a doctor that goes up there maybe once a month. We are now in 11 communities doing estimated GFR, some basic biochemistry, blood pressures, hemoglobin A1C, urinary ACRs, and right at the point of care, we're using our custom-based app that we've created to do a kidney failure risk equation and really stratify that individual in terms of risk, whether they need to be seen by a nephrologist. So in about 15 minutes or less, we are doing sort of a fairly comprehensive chronic kidney disease screening and diabetes screening program. As of October of this year, just recently, we just screened our 1,500th patient in 11 communities across Manitoba, 3 of which are in the Garden Hill area where that very expensive dialysis unit is. This is why people live there. It's very beautiful, but there's a lot of, obviously, public health problems that exist there. So in terms of a risk-based team approach, we see low-risk patients are not seen by nephrology. These are less than 3%. This is about 20% of the patients we've screened. So about 30% of the patients we've screened have some form of chronic kidney disease in these communities, so very staggering compared to about 10 or 12% of the general population. On low-risk patients, we refer to their primary care infrastructure if it exists. We focus on lifestyle, we focus on blood pressure targets, but we also are enrolling all these people into a chronic disease surveillance database where we'll be able to pull their data from Manitoba Health repositories into the future and make sure that they are rescreened. Anybody at medium risk or high risk of kidney failure in the next 5 years, this is again greater than sort of 3%, gets immediately referred to a nephrologist in Winnipeg, some of which we do by telehealth. And the ones that are deemed needing interdisciplinary care are right into those clinics I described earlier. So they are seen by the nurse, the dietitian, the pharmacist, and the physician in a very predictable fashion. And greater than 15% kidney failure risk equates to usually your patients with the GFR in the 20s or lower. So obviously this is just sort of the cutting edge of trying to tackle this major public health problem we have in Manitoba. What we are working on next is to embed some of these risk prediction algorithms into our EMRs. We have 4 EMR vendors in Manitoba. There's 2 of them that have about 90% market share of all the sort of primary care EMRs. We're going to embed these algorithms into their primary care EMRs so that they can instantly get prompts to refer patients to nephrologists. We want to try doing a randomized control trial in screening communities versus maybe just other communities doing some capacity building or training lay workers to educate people about chronic kidney disease to see if this really is a case-finding thing that is improving health outcomes downstream. And again, we're building this surveillance system for CKD using our administrative data as well as the Promise platform in Manitoba that we've implemented a couple of years ago. This point-of-care equipment we're currently using is about 600 pounds. So when we take all of our analyzers and blood pressure equipment and so on, we're shipping up a lot of equipment from community to community. We're usually there for a couple of months when we're doing our screening. But what we want to work on is more miniaturized, novel point-of-care testing tools. Testing maybe biomarkers we're not currently using now. Instead of just using creatinines, maybe cystatin C or NGAL or a variety of different biomarkers. So we're doing all this with one finger prick of blood. So we've got some engineering grants right now we're working on, so sort of miniaturize this equipment, but also achieve the same information with maybe a little bit less weight and cumbersome equipment. And the next thing we're working on as well is for our high-risk patients, the people with interdisciplinary clinics, my alarm's going off here, is looking at potentially wearable tech sensors and streaming data. So wearable tech sensors meaning something like the iWatch or even something as simple as a Fitbit device that measures motion in patients to see if patients that are moving less or potentially having aberrations in some of their basic vital signs need to be seen more frequently in clinics and so on. So we can better sort of allocate our interdisciplinary clinics in terms of aligning resources with risk. So I'll stop there. Thanks very much. I'll take questions.
Are there studies being done about why there's such, maybe I'm reading your graphs wrong, but there is such a high level of renal failure in your northern, is it environmental, is it social, and is there something being done about that?
Yeah, it's all the above. So there seems to be in some of the First Nations tribes that are in northern Manitoba and northwestern Ontario, there are some genetic factors that they're getting very malignant diabetes. So very early metabolic syndrome, high levels of proteinuria even in teenagers, even before they're diagnosed with diabetes, and of course, very rapid progression to kidney failure. But this didn't exist 20 or 30 years ago. This is a very modern problem. So there is something to probably with gestational diabetes, with diet and so on that's turned on these genes, and they're rampant now. So it's not just a public health problem that nephrologists or endocrinologists can solve. It's not just diet, although that's a component. There is something likely genetic going on, but there are some structural things that we've created, like having 5,000 people living in a reserve with 80% unemployment and no road access, that we can likely, from a policy perspective, break down those barriers. It's a very sort of complex problem. We're just sort of doing what we can to find patients early.
So that was great, thank you. I'm very interested in looking at point of care risk prediction. There's an X Prize currently ongoing, where there's a big prize put out to any company or any individual who can create a point of care sort of medical tricorder. It would seem that what you're doing with kidney risk prediction at the point of care would sort of fall in that category. There are a number of companies who are gaining a lot of ground and a lot of traction. The biggest name would be Scanadu. Have you talked to any of these folks about integrating the kidney risk prediction?
It's a great question, and we're not, I guess there's a couple of issues right now. Is how do we get we know kidney failure risk equation's okay. It's about a 90% sort of C-stat. It's a 90% chance of predicting accurately kidney failure in 2 or 5 years. We don't know that novel biomarkers, and Dr. Tangri's spoken extensively on this, any novel biomarker, any new serum rhubarb is going to boost the performance of that equation further. The question is, how do we get simple data from point of care, likely finger pricks, into these algorithms that can rapidly give the information back to practitioners? And right now, although we're relatively small, our boxes are probably the size of these speakers, are still relatively big, having to go up, they need to be calibrated and so on. It's much better than having to do venipuncture and shipping serum samples to mega labs. But we are working on sort of engineering these down to a smaller size and integrating the app right into the tricorder, so to speak. We have a commercialization grant, so an NSERC CIHR grant right now to work with engineers on developing these things. So these micro-channel platforms are being worked on currently. And we do have some commercialization partners for that already. I'm interested to talk more about those tricorder grants that I've read about.
Perfect. Any other questions?
Thank you for the very interesting presentation. Just one question about the performance measures, the team performance measures at the CKD clinic. Do you also look at the quality of the care that people are getting, such as the effectiveness of it? Is like some people might require longer time versus shorter time depending on what their needs are, as well as the patient experience?
Absolutely. So that's a whole talk in of itself. I kind of glossed over it a little bit. We have published on this in terms of quality of care parameters for the interdisciplinary clinic, more PD starts, less ER utilization, and likely better parameters around mineral metabolism and so on. So there is certainly quality of care advantages to this type of model. The question around patient experience comes up quite frequently. We don't set a stopwatch and bang a gong when 15 minutes is up and get people out of the room. We do give people as a guideline that 15 minutes from our extensive work on timing patients is about the time people naturally spend with patients. But as I mentioned, there's a lot of heterogeneity around that. I picked on the physicians, but pharmacists are just as bad. Pharmacists could spend anywhere from 4 minutes to 35 or 40 minutes with an individual patient. And really, it comes down to the question of every single patient deserves at least some baseline level of care. And what was happening is patients booked really early in the clinic were seeing everybody and seeing everybody for a long time. And as the clinic would get busier and we got closer to bumping up against noon or 5 o'clock or whenever that clinic closed, patients were just seeing the physician because the allied health were sort of extracting themselves and saying, and really had not necessarily much relevance to patient risk. So the 15 minutes thing is the baseline level of care everybody gets. That does not mean that pharmacists can't follow up after, dietitians can't schedule other appointments, nurses may need to do EPO teaching, so they may need to take patients out of the flow of the clinic and teach them outside, but the flow of the clinic stays the same no matter what. And so the patient experience question is a great one. Our patients were spending up to 3.5 or 4 hours trying to see all the practitioners in the clinic previously. Now everybody's in and out of there in less than an hour and 15 or an hour and 20 minutes. So overall, our patient satisfaction scores have gone up by about 1 or 2 points on our Likert scales.